Hello, today we're talking about pericardial disease and cardiac tamponade. The slides and content were created using Google Gemini and Notebook LM. Starting with the anatomy of the pericardium is a stiff, inelastic sac. It's got a fibrous pericardium on the outer side called the parietal pericardium. You can imagine the inner layer of the pericardium as a flaccid balloon into which the heart is pushed, creating a double layered structure. This is filled with a small amount of fluid, usually 15 to 50 ml. This fluid is an ultrafiltrate of plasma. Pondering on the anatomy of the pericardial sac merges with the root of the aorta and has transverse and inferior sinuses. The merging with the root of the aorta has important implications clinically, as we will learn through the presentation. It's important to realize normal respiratory hemodynamics. In inspiration, there is negative intrathoracic pressure. The inspiration does not impact the pressure in the veins outside the thorax. Therefore, there's a difference in pressure between peripheral veins and intrathoracic veins, leading to increased venous return. This increased venous return causes slight leftward septal shift and a minimal decrease in LV stroke volume. In expiration, the reverse happens. In tamponade, the core principle is tamponade occurs when intrapericardial pressure exceeds right atrial pressure. If this is acute, such as trauma, 100 to 200 ml of fluid is enough to cause a tamponade. If it is chronic, slow accumulation, such as malignancy, you may have a liter or two of fluid without causing tamponade. Rate of accumulation determines the clinical severity, not the absolute volume. There is ventricular interdependence. What that means is the pericardial fluid prevents the right ventricle from expanding outwards like it usually does with inspiration. Therefore, the septum moves towards the left ventricle, and this causes a drop in left ventricular output. Additionally, diastolic pressures normalize or equalize actually. For example, right atrial pressure may be 18, RV 18, PA 18, wedge pressure 18 in diastole. Whenever you see something like this, you should always consider tamponade. The classic Beck's triad is noted in less than half the patients, includes hypotension, elevated jugular venous pressure, and muffled heart sounds. Muffled heart sounds are a result of insulating effect of pericardial fluid. Elevated jugular venous pressure is because of venous buildup. Hypotension is because of left-sided decreased cardiac output. Clinical signs include pulsus paradoxus, and the mechanism has to do with the septal shift, like we discussed. There's an exaggerated drop in systolic blood pressure, more than 10 millimeter mercury during inspiration. Now, for measuring pulsus paradoxus at the bedside, this is an important skill to learn. In the first step, you inflate the blood pressure about 20 millimeters above the automated systolic blood pressure. Slowly deflate. Notice the point where you start palpating on the radial pulse or auscultating the irregular Korotkov sounds. Keep deflating. Then the Korotkov sounds become regular. Note this point. When the difference between where the Korotkov sounds are irregular and where they are regular is more than 10, this is pulsus paradoxus. Now, comparing tamponade to constriction. In tamponade, JVP falls normally with inspiration. In constriction, there's a paradoxical rise in JVP, which is called the Kussmaul sign. There is tachycardia noted, and there is a narrow pulse pressure in patients with tamponade. In the electrocardiography, there's electrical alternance with a variation in QRS amplitude caused by the heart swinging in the pericardial fluid. There's PR segment depression. Electrical alternance is highly specific, not sensitive, for a large pericardial effusion. And echocardiographic features include right atrial collapse, right ventricular collapse, dilated IVC, inflow variation. So when you put a cursor at the mitral valve inflow, there's a variation by 25% of the Doppler signal. And cardiac catheterization, there's equalization of pressures and prominent X descent with a blunted Y descent is noted. The differential diagnosis includes tamponade constriction and restriction. In tamponade, on RA waveform, there is fluid compression, blunted Y descent. In constriction, there is a prominent X and Y descent with a dip and plateau like a square root sign. In restriction, there is a stiff myocardium with a prominent X and Y. An echocardiogram, tamponade, there is chamber collapse. In constriction, there is septal bounce. In restriction, globally reduced E velocities. The treatment for tamponade is pericardiocentesis, for constriction, pericardiectomy, and restriction is medical management. There is a condition called low pressure tamponade which occurs in severe hypovolemia such as motor vehicle accidents. When fluid is repleted, then the tamponade manifests itself. Regional tamponade can happen in patients who undergo cardiac surgery. In aortic dissection, type A, the blood leaks into the pericardium. Tapping such a tamponade is absolutely contraindicated. Emergent pericardiocentesis is life-saving. Unlike the image shown, usually a subxiphoid approach is used, or echocardiographically you identify the area where there is the largest amount of fluid and you tap from there. Alternatively, a pericardial window or surgical procedure can be done. Fluid should always be sent for analysis. Here are certain pearls. Trauma with hypotension, elevated jugular venous pressure, and clear lungs. Consider acute cardiac tamponade. Cancer patient with progressive dyspnea and pulsus paradoxus. Chronic malignant effusion with tamponade. Post-MI day 5 with sudden hypotension JVD. Free wall rupture with tamponade. Post-bypass hypotension despite functioning chest tubes. Loculated regional tamponade. EKG alternate QRS with tachycardia, swinging heart with a large effusion. Now moving on to acute pericarditis. Acute pericarditis has multiple inflammatory pathways activated. In the treatment of acute pericarditis, we use nonsteroidals which act on one pathway, IL-1 inhibitors which act on a separate pathway, and steroids which act elsewhere. Now, pathophysiology, it can be triggered by infection, post-MI, autoimmune, and metabolic factors. Classic presentation is sharp pleuritic central chest pain, which radiates to the trapezius, worse on lying down, improved on sitting up and leaning forward. Pathognomonic sign is a pericardial friction lub, which is a high-pitched squeaking, grating, like pieces of leather rubbing to each other's sound. This can be transient. It's best auscultated by firmly applying the diaphragm to the left lower sternal border and having the patient lean forward and breathe out. ESC diagnostic criteria for acute pericarditis include typical pericardial chest pain, pericardial friction rub, widespread ST elevation, new or worsening pericardial effusion, 2 of these 4. Now, EKG shows 4 signs of stages of evolution, although not present in every patient. Stage 1 is widespread concave upward ST elevation. Stage 2, ST segments return to baseline. Stage 3, diffuse T-wave inversion. Stage 4, gradual resolution. Now, the ST elevation should be differentiated from STEMI as well as early repolarization. The ST segment is diffuse concave upward in pericarditis, and AVR and V1 will classically show the inverse. There's also PR segment depression. In STEMI, the shape of the ST elevation is convex upward. There's anatomic distribution. Reciprocal ST changes are seen. PR depression is absent, and there may be Q waves noted. Look at the cartoon on the right. A concave ST elevation is pericarditis. Now, convex is STEMI. Early repolarization can be differentiated from pericarditis by noting the ST elevation and the tallest point of the T wave. A ratio greater than 0.25 suggests acute pericarditis. Also, there's a fish-hook pattern noted. A fish-hook pattern on ST elevation is typically noted in lead V4 in patients with early repolarization. There's a multimodality imaging pathway used. Commonly, almost everyone gets an echocardiogram, which may show pericardial fluid. You can assess for tamponade. You can look for diastolic RV collapse, rule out myocardial ischemia, absence of segmental wall motion abnormalities. CT scan is excellent for evaluating pericardial thickness. Cardiac MRI is the gold standard. Cardiac MRI shows the anatomy, shows edema, shows late gadolinium enhancement, which is a sign of inflammation. The treatment of pericarditis involves first line treatment with NSAIDs with colchicine. Second line for recurrent pericarditis would be corticosteroids, and then interleukin 1 agents. Interleukin 1 agents were found to be effective and have more side effects. ACC AHA recommends use of colchicine and NSAIDs, exercise restriction as first step. Second step is interleukin 1 agents. Third is steroids, and radical pericardiectomy is saved for refractory cases. There is a flow chart presented by the ACC which goes over how to manage these patients. Interleukin 1 agents for more than 12 months or can be long term in recurrent pericarditis. So there's a paradigm shift in managing recurrent pericarditis. Traditional approach was corticosteroids, that's not in favor anymore. And interleukin 1 agents are becoming more important. Thank you for watching. More to follow.